So I'm pleased to introduce Dr. Nguyen. He is a urology surgeon at Metro Health Medical Center, and he's going to talk to us about the surgical options for men with prostate cancer. So let's welcome Dr. Nguyen. Thank you.
Well, good morning, everyone. I'm Carvell Nguyen. I'm a urologic oncologist from Metro Health Medical Center. It's an honor to be here today to share some hopefully relevant, important information to all of you about how we're treating localized prostate cancer. Now, I think I came in at the end of Dr. Spratt's presentation and Dr. Menorata's excellent presentation, so now you've gotten an idea of different treatment options and how we can treat advanced prostate cancer. But the focus of my talk is going to be on mainly the surgical treatment options for localized or organ-confined prostate cancer. So cancer that has not spread outside of the prostate and is potentially, theoretically, curable. So the first thing, no financial interest or relationships to disclose, especially regarding any of the companies whose products and devices that I'll be discussing today. So in the past, prostate cancer, as soon as somebody would be diagnosed, we would treat them. And so whether it was surgery or radiation treatment, everybody got treated. And historically, and certainly before the advent of PSA testing, prostate cancer was diagnosed at relatively advanced stages. And so for many of those men decades ago would merit treatment. And so often it was a knee-jerk reflex. Somebody got diagnosed, they would get treated. But we're taking a much more nuanced approach to treatment of prostate cancer today. And yes, I think we can all agree that cancer is bad, but not all cancers are actually created equal. So the mainstays of treatment, as we've already discussed today, historically have been surgery, represented by radical prostatectomy, as well as radiation treatment. And again, we're talking about organ-confined, localized prostate cancer. Both of those have been shown to be very effective in curing localized or organ-confined prostate cancer, and there's decades of data to show this. The problem, though, is that even though both surgery and radiation are great at curing prostate cancer, they can be associated with significant side effects, often affecting quality of life. Examples can include urinary incontinence, so leakage of urine when you sneeze, cough, or laugh, sexual dysfunction in the form of difficulty getting erections, loss of the ability to ejaculate, bowel health. Bowels can be damaged by radiation. So there are a lot of things that can certainly impact a patient's quality of life related to the risks and complications of treatment. So that line is off a little bit there. I apologize for that. Should have underlined the do no harm part. So obviously, when somebody comes to us with cancer, we want to try to treat it. That's the part where we try to do good. But as we just mentioned, doing that good can also carry secondary harms to the patient. And so I think that many of us now are focused on not only treating the cancer, but also trying to do as little harm as possible, maintaining quality of life and reducing those harms. So I think that for most physicians who treat prostate cancer, whether it's urological surgeons, radiation oncologists, medical oncologists, we all share a common goal. And that includes, obviously, enhancing survival, so reducing the risk of dying from disease. But as Dr. Menorata mentioned many times, that we want to try to maintain that quality of life for patients. We want to try to reduce harms, and harms can come in the form of physical harm, like pain, psychological harm, stress, anxiety related to the cancer diagnosis or the process of undergoing treatment, the financial harms of undergoing treatment and the cost associated with medicine, with surgery, and maintaining quality of life. So the evolution, we started off by treating everyone, but I think that the current paradigm is focused on targeting and tailoring treatment to the individual patient. And this requires recognition that not all cancers are created equal, as I mentioned a while ago, and not all cancers are inherently bad, especially when it comes to prostate cancer. Many prostate cancers that we diagnose are very slow-growing. One of the slides on Dr. Menarata's presentation mentioned that over 90% of prostate cancers are organ-confined, and that's basically true. And that's because many prostate cancers are diagnosed early, before they've had a chance to spread. And some of those cancers may not cause any illness during the lifetime of a particular patient. So there's a question of whether that sort of cancer even needs to be treated. And so now we need to focus on treating the patient, the individual patient, and not just the overall disease. And so we want to try to individualize treatment plans. So one of the ways that we've been doing that is by making treatments more effective, but trying to minimize the harm. And the strategy here is to emphasize less invasiveness with fewer risks. And some of the ways that we've been doing that, by offering active surveillance and recommending active surveillance more often to patients who are eligible for that. For patients who desire or may benefit from surgery, we're trying to make that surgery less harmful by making it less invasive via laparoscopic or robotic approaches. I'm sure that Dr. Spratt already talked about some of the evolution and improvements in radiation by shortening courses and focusing the radiation so that there's less collateral damage to bladder and rectum. And then probably one of the newer, more novel forms of therapy is something called focal therapy, which I'll discuss at the end of the presentation. So the first strategy in that list was active surveillance, and this was something that in the early days of prostate cancer treatment, relatively foreign. Again, the thinking is that all cancers are bad, they all need to be treated. We can't just let cancer fester in somebody, can we? And the question to that, the answer to that is actually, in some cases, we can. So some of the statistics here that are important to know. Most men diagnosed with prostate cancer actually do not die from it. Right? And this is readily available from the American Cancer Society, and has shown that approximately 1 man in 41 will actually die of prostate cancer. So that's less than a 3% mortality rate. And that's looking at all comers. Okay, that's looking at all men diagnosed with prostate cancer, many of whom have low-risk disease. There are a small percentage that may have advanced or metastatic prostate cancer. Those are the patients that go and see Dr. Menarata. Those patients' risk of death are certainly higher. But looking at all comers, the risk of dying from prostate cancer is actually very low. And in fact, right now, as we speak, there are more than 3 million men in the United States that are living who have been diagnosed with prostate cancer. Either they've been treated and cured, or potentially they're living with prostate cancer that is being surveilled, or they're living with advanced prostate cancer that is being controlled with the many forms of effective therapy that we have today. So the reason for this longevity for men with prostate cancer, some of it could be due to effective treatment, but I think most of it is due to earlier detection of prostate cancer in the PSA era. So because of PSA testing, which became available in the mid-'80s, I think, prostate cancer has been diagnosed at much earlier stages and grades, and men who have these low stage and grade prostate cancers often demonstrate indolent courses of disease, slow growing. And in the past, historically, active surveillance has been severely underutilized. This is a somewhat busy slide, but what it's demonstrating is, so in gray here are this represents the percentage of men who were managed with expectant management, i.e. active surveillance. Blue represents surgery, Yellow represents seed therapy, radiation therapy, and then you have some other forms of therapy up here. These are stratified by the risk of disease progression, low, intermediate, and high. And you can see that in patients with low-risk disease who have a very low risk of cancer mortality, the 15-year risk of dying from disease for low-risk patients is probably, again, less than 3%. And you can see that the utilization of active surveillance was very low in this patient group. And so we have been overtreating prostate cancer for a long time. So what's the data behind that? What's the data to argue for active surveillance? And there was a landmark trial that was originally published in 2016 and then updated just recently, several months ago. It's called the PROTECT trial, Prostate Testing for Cancer and Treatment. It was a large trial that was run in the UK, where they basically took a huge cohort of men who were screened for prostate cancer with PSA testing. They diagnosed about 2,700 men, I think, and 1,600 men with localized prostate cancer were then randomized to 3 forms of management: active surveillance, AS, radical prostatectomy, RP, or X-ray therapy, right, radiation therapy. So this was a landmark trial to try to figure out, well, which one is better? Which treatment option is the best? And as you might expect, looking at some of the outcomes, for example, the rate of disease progression. So disease progression is represented by the cancer growing, which can be demonstrated by the PSA going up. It could be represented by finding a metastatic disease on imaging tests. The patient can potentially have symptoms of that progression, like bone pain or urinary symptoms. The rate of disease progression was higher in patients who were simply watched, active surveillance, compared to those who underwent prostatectomy or radiation treatment. However, the critical piece of data was that there was really no significant difference in survival in those 3 groups of men at either 10 years or 15 years. And the risk of death was about 3%. I think in the active surveillance group, it was 3.1% of those men had died at 15 years. Surgery, I think, was 2.2% of those men had died at 15 years, and radiation, I think, was about 2.6 or 2.7. So regardless of the treatment option that was chosen, the risk of dying from disease at 10 and 15 years is very low. So active surveillance is a very good option for patients. Now, for those patients who desire surgery, or for those who we believe that surgery may be a better option because of being intermediate risk disease or higher volume disease, or potentially very young patients where they may have a lot of time, and even an indolent cancer, if given enough time, can potentially progress and cause symptoms. So historically, we've done prostatectomy via an open approach. And by definition, all surgery is invasive, but open surgery is maximally invasive. So the larger incisions are associated with more pain, longer recovery time. There can be cosmetic concerns because of the scar. The minimally invasive approaches that we use, laparoscopic surgery, robotic surgery, focal therapy, we try to minimize the number of the incisions to try to minimize the impact of issues like pain, recovery, cosmetic concerns. So in the past, surgery was done via an open approach, and you can see some examples of the incisions that we once utilized. A lower midline incision there that we call the retropubic approach, or even something that is even more outdated called the perineal approach, approaching the prostate from below. This is an example of what one of those incisions would look like. So not too big as far as incisions go, because it would be basically below the belly button running to the pubic bone, but still quite invasive. And you can see the prostate there in the middle of the field right here. That's the prostate. And the end result would be that the prostate would be removed. Hopefully all the cancer would be removed with it, and you'd have the bladder reconnected to the urethra. But again, bigger incisions carry with them more complications, higher risks, longer recovery. So we developed laparoscopic surgery. And this is a bit of an exaggeration here. Obviously, open prostatectomy specimens incisions are not that long. I don't know exactly what this patient had done. He basically had a stem to stern. So this is not how open prostates used to be done. I just want to say that. Those incisions were limited from the belly button on down. But the laparoscopic incisions here are quite representative. And so you can see the significant difference. And long incisions can be quite painful. This is how the laparoscopic surgery was done. You can see that you have keyhole incisions through which these ports are placed, and then you have special instruments as well as a camera that are introduced through the ports to be able to manipulate the organs, and in this case, remove the prostate, avoiding the long incision and the disadvantages associated with that. This was a typical setup that we would have. You would have at least 2 surgeons, one person driving the camera, another person manipulating the laparoscopic instruments, and we would be looking on a screen that was displaying the image transmitted by the laparoscope, the laparoscopic camera. So what are the advantages of laparoscopic surgery compared to an open approach? There are many, actually. The camera provides a greater magnification, and you can see often in high definition, so you can see much better than even with the naked eye. Less operative time. I noticed that there's an asterisk next to that, and that's basically, it's based on the skill level of the surgeon. So for someone who is well-versed in the laparoscopic approach, the surgery can be much shorter than an open, but the learning curve can be steep. So if you have someone who's less experienced, they might take a longer time doing it laparoscopically compared to the open approach. The smaller incision, shorter operative time can lead to earlier recovery, better postoperative function in terms of easier breathing and lung function, getting up, walking around, getting back to work faster, shorter hospital stay. And this is definitely something that we've seen. Open prostates that might require a 2 to 3 hospital day stay, now down to 1 day typically, and sometimes patients would even go home the same day, and better cosmetic results. But today, laparoscopic prostatectomy is actually not done not done very much. It's been replaced by robotic surgery. And so what is robotic surgery? So I'm going to go back to this slide real quick, just to show you again the setup for how laparoscopic surgery is done. Again, you have to have 2 surgeons, one driving the camera, one actually working the instruments. The surgeon is working the instruments, him or herself, and you're looking at a 2D image, right? So with the robot, we can mitigate some of those disadvantages. Number one, you can have one surgeon operating at the console, and that one surgeon can essentially control most of the functions that you saw on that prior slide. So the surgeon can control the camera, and the surgeon can control the arms. And as you can see here on the image, the current generation of the Da Vinci robot actually has 4 arms. So one arm is meant to hold the scope, the camera, and then the other 3 arms are meant for instrumentation. And so the robot is very versatile in that way, because obviously it can take the place, or it can allow us to consolidate 2 surgeons down into 1. Right? The other advantage of the robot is, unlike a human, the robot doesn't get tired. It has no tremor. It doesn't talk back. And so it's actually, it's nice because it focuses and consolidates those efforts. I remember when I was a resident and we were doing laparoscopic cases, the inherent inefficiency of the system was made clear to me one day when I was operating with one of my attendings, and it was the last case of the day. We were both tired, and he was getting short with me, but we were doing the surgery, and I just was not showing him what he needed to see. And he got upset, and instead of using his words, he just said, "Carvell, just show me what I need to see." Right? That doesn't help me at all. I don't know what you need to see, so you need to tell me what you need to see. And so the nice thing about the robot, I can't yell or argue or get frustrated with anybody because I'm controlling everything. And so that's what makes robotic surgery much more efficient. So what isn't robotic surgery? There are a lot of misconceptions surrounding robotic surgery. I had one patient who asked me, so with robotic surgery, do you just go and program it and then grab a coffee and then come back when it's all done? I was like, no, that's not what happens. There is no autonomy to the robot, okay? So the robot, it's misleading. It's a misnomer because there's no automatic or autonomous nature to the robot. The robot doesn't do anything unless I am controlling it. So unless I'm sitting at the console, moving the arms, and transmitting those movements to the robot, nothing happens at the level of the patient, right? So there's no autonomy whatsoever. That might be something that happens in the future, autonomous surgery, but not now. Yeah. So what are the benefits? So we've talked about some of them. Probably the biggest benefit, I think, of the robotic platform is the greater range of motion, and that's seen in this picture up here. So you can see that the robotic instruments, not only do they articulate at the very end, so for example, the scissors, you can see that the scissors move, or the graspers can open and close. But the instruments also have an extra layer of articulation called the endo-wrist, which basically emulates a human wrist. So you all can experiment at home and maybe spend half a day trying to do things around the house without moving your wrist and see how difficult that is, all right? And that's the limitation of straight laparoscopic surgery. And in fact, one of the names that we give pure laparoscopic surgery is stick surgery, because that's what it is, it sticks. There's no articulation at the wrist. Having this endo-wrist articulation allows us to do much more complex and precise movements, like sewing inside the body and other reconstructive maneuvers that you can do easily with your hands, but with laparoscopic instruments can be very challenging. As I mentioned, there's more control by the surgeon. We're doing more of what used to require 2 people. You notice that in the picture, the surgeon gets to sit down. I have to admit, I like that, especially if we're doing a surgery that takes 7 to 8 hours. And I just believe that if the surgeon is more comfortable, that inherently will lead to better outcomes for the patient. Now, what are some of the disadvantages of the robotic approach? So one of the disadvantages in the past was cost. And the robotic approach to most surgeries that were done, whether it was prostatectomy, removal of someone's gallbladder, removal of an appendix, it used to be more expensive. There's no doubt about that. But because of improvements in technology, decreased operative time, as well as advances in manufacturing and technology by the company itself, Intuitive, prices have been driven down significantly. And in fact, these days, robotic procedures are the same price, if not cheaper, than the laparoscopic approach. So cost is no longer a disadvantage or a reason not to do robotic surgery. There can be a longer setup or procedure time, and there can be a higher learning curve when surgeons are first starting out, or when a hospital first adopts the robotic system. But robotics is essentially ubiquitous now. All academic institutions have robotic programs. Most community hospitals now have robotic surgeons and robotic systems. What are some of the misconceptions? I don't know, some of you may have read that recent New York Times piece on, I think it was on robotic hernia repairs, and how adoption of this relatively novel technique has led to greater complications and risks for patients. And that can be true for any new approach or technique or instrument. And the important thing to realize is that the robot, even though it is technologically advanced and it's very expensive, it is nothing more than a surgical instrument. It's a very expensive pair of scissors and scalpel and whatnot, but it's still an instrument. So in the end, the outcomes are going to be dependent upon the surgeon, the skill of the surgeon, the skill of the support team. and not the robot itself. One of the concerns I've had from patients is that, what if the robot malfunctions? What if it goes crazy and it starts doing things and harms me? So number one, that doesn't happen. Again, there's no autonomy to the robot. But I think the question of malfunction is a relevant question. And I'll tell you that in the nearly 20 years that I've been doing robotic surgery as a resident fellow and then as an attending, I have never experienced, personally or secondhand through a story from a colleague, that a malfunction of the robot directly led to patient complications. That has not happened. I'm not saying it's never happened anywhere, but in my experience, it's never happened. Now, the robot has malfunctioned. And just like with anything in your house that's electronic, what do? You power it off, you power it back on, right? You reboot your PC. That fixes most things. So it's the same thing with the robot. It stops working, you reboot it. Now, sometimes if that were to happen, if the robot malfunctioned and you had to reboot in the middle of a critical portion of a case, that could be problematic. But knock on wood, that's not happened to me. I have heard of that happening in some cases. But that's a very rare occurrence. And again, you can have complications and fluke incidents with or without the robot. So those are some of the things that I wanted to try to clear up for anybody who is interested. So I just wanted to show you a quick, short little video on what it is that we see when we're doing a robotic case. And this is a video from Dr. Lau, who is a urologic oncologist, robotic surgeon, City of Hope in California. And this portion of the case is where he's dissecting out the bladder neck. Well, it did say that the laptop was losing power. So do we have the AC adapter? So while we're getting that back up, hopefully you're able to see a little bit of that video. Again, they were dissecting out the bladder neck, the junction between the bladder and the prostate. And what I wanted to be able to demonstrate with that video is number one, the visualization. And that's a two-dimensional picture. When we sit at the console, we are able to see everything in 3 dimensions. And so we have depth perception, which obviously helps with surgery as well. The other thing is you can see the level of control, the fine, meticulous control that the surgeon had in moving the scissors, the grasper. The suction tip is actually from the bedside assistant. We do have to have someone at the bedside at all times to be able to switch instruments in and out and to provide support like suctioning blood and other fluids. But just the fine movement, and literally moving in millimeters and being able to gently brush away the muscle fibers and getting down to the correct plane, that's something that we could never do open or even laparoscopic. All right, perfect, thank you. Let's see here. All right, so again, if you look at this, you can look at how he's able to manipulate the tissue so meticulously and without damaging anything else other than what he wants to cut and cauterize with those scissors. Now, just to give you a sense of scale, the tip of those robotic scissors measure about maybe a little over a centimeter. So the tip of the scissors is potentially half of an inch. So it just goes to show you the scale here and how magnified the image actually is. So again, you can see how much control he has, how he's able to minimize bleeding and damage to surrounding structures. And I think that this is a huge advantage of the robotic approach. So robotic-assisted laparoscopic prostatectomy is probably, I consider it the gold standard now for surgical removal of the prostate, RALP for short. It is probably one of the most common robotic procedures done nationwide, if not worldwide. And now, in fact, I would say that at least 85% of all prostatectomies are now being done with the robot. I think the only people who are doing it non-robotically are probably older generation surgeons who have not been trained robotically, and they're more comfortable doing it open, and there's nothing wrong with that. And again, as I mentioned a while ago, it's more the surgeon than the instrument that determines outcomes. So open surgeons, open prostatectomists can have excellent outcomes, cancer, and even quality of life. Although, again, I believe that the robotic approach does have some significant advantages to quality of life issues. Some of the benefits of the robotic approach over open and even the laparoscopic approach. I think that, again, with that video, I hope that video was able to demonstrate how meticulous our surgical dissection can be, but less blood loss, less pain, shorter hospital stay, improved urinary continence, improved preservation of sexual function. And as I mentioned a while ago, there are some institutions that are doing prostatectomies as an outpatient procedure where the patient is literally going home a few hours after the surgery has been done. So what's on the horizon? The next step, I think, is going even less invasive. So how can you be less invasive than those 4 incisions that I showed you a while ago? Well, now we're going to go through 1 incision. And this is called single port robotic surgery. So Intuitive, the company that makes the robot that most institutions use now, the Da Vinci, came out with the single port robot in 2018, so a relatively new technology. And as you can see here, this looks like something out of a science fiction movie, but all the instruments actually do fit through this 1 port, and the instruments themselves are articulated at the end so that they're more flexible, as you can see here. So you can see that once the instruments deploy through the port, then they can flare out, and now you have this thing that looks like, something from the Matrix. This is the single port robot docked to the patient, and again, it's going through 1 incision. So obviously, it's something relatively new. It's only been available since 2018, but there have been preliminary data that have been published that show that doing a robotic prostatectomy via the single port approach is safe and feasible, and in properly selected patients, outcomes can be similar to the standard multi-port robotic approach. The advantage of the single port is that we can go via an extraperitoneal or transvesical approach. So extraperitoneal means that we avoid the peritoneal cavity. That's the space where your intestines are. So avoiding the space where your intestines are can obviously avoid damage to the intestines. It can avoid the irritation that can lead to what we call ileus following surgery, which is where the intestines go to sleep, and it can take days for them to wake up, and then you're in the hospital, you're miserable, you're full of gas, you can't poop, you can't fart, you can't eat. So none of that is pleasant. By doing an extraperitoneal approach, you can avoid those complications. Transvesical is actually going through the bladder. So instead of having to go through the peritoneum or even the extraperitoneal space, we go through a natural orifice into the bladder, and then we core out the prostate from the inside. Advantages are decreased invasiveness, cosmetic appeal, single scar or even scarless, because if we go through the umbilicus, the belly button, and sew that back up, afterwards, in many cases, patients don't even know, or no one else looking at it would know that they'd had surgery, because the incision would be hidden by the belly button. Better pain control, because instead of having 4 or 5 keyhole incisions, now you have 1. This is a potentially good option for patients that have low and intermediate risk disease, those that do not have a high risk of disease spread outside of the prostate. It's especially good in those patients who've had previous abdominal surgery. Anytime that somebody's had previous surgery, there's going to be a lot of scar tissue inside the abdomen, and that can make subsequent surgery much more challenging. So if we can avoid all of that previously operated space, all the better. And then smaller prostates, I think, are a better approach for this. So this is something that we are going to be offering at Metro. We are bringing in the single port robotic unit. And so we'll probably be offering it to patients that are, again, properly selected based on those criteria. Last thing I wanted to talk about is focal therapy. And this is a relatively novel treatment as well, although the idea and the execution of focal therapy has actually been around for at least a couple of decades. But it's probably in the last decade or so, it's been receiving more traction and interest. And what focal therapy is basically treating only the tumor itself. So if somebody has one dominant tumor, it's treating just the part of the prostate that has the cancer, but sparing the rest of the prostate. So it's focal gland, partial gland therapy, in contrast to surgery and radiation, which have been typically examples of whole gland therapy. So the goal of focal therapy is to control cancer, but spare normal tissue so that we can preserve sexual function, urinary function, prevent damage to the rectum. So this slide shows you some of the ways that we can achieve focal therapy. So one way is just by treating one area of cancer. So if a patient has just one focus of cancer, we can try to isolate that focus and we can treat it. And again, the rationale for this, the impetus for this, is to try and spare and preserve vital structures that facilitate urination, so the urethra. And then there are nerve bundles that are just outside the prostate that sit at 5 and 7 o'clock. These are the neurovascular bundles. They facilitate erections. So damaging those nerves reduce a man's ability to get spontaneous erections after a surgical procedure. So if we can stay away from those nerves and at least preserve one, theoretically, a patient can preserve their spontaneous sexual function. Other ways that we can do focal therapy, we can do, if there's a multifocal, but it doesn't take up the entire prostate, we can treat those. For patients that have multifocal disease, but if they have one index lesion that is potentially aggressive, but the other ones are the low-risk cancers that we don't have to worry about treating, for example, the Gleason 6 disease, we can leave those alone, and we can treat the one that is potentially progressive. Or we can treat one half of the gland. We call that hemiablation. This is an example of a setup for focal therapy. It's usually done transperineal. So we use an ultrasound that goes into the rectum that allows us to visualize the prostate. And then we insert the probes or the energy devices, and there are a number of them, through a grid into the prostate. All right? This grid, if anybody's played Battleship, that's essentially what this looks like. So we're playing Battleship with the tumor, all right? So the Battleship grid allows us to localize and stabilize the energy devices. And again, the key thing with focal therapy is that we want to try to spare and protect vital structures surrounding the prostate, including the rectum, the bladder, the urethra, and the external sphincter. The external sphincter is the band of muscle outside of the prostate that allows us to control our urinary flow. So there are many forms of focal therapy. The important thing to realize, though, again, this is still relatively novel. There have been no head-to-head studies comparing all the different forms of focal therapy with each other, or comparing focal therapy to the standards of care, which are surgery and radiation, and for low-risk disease, active surveillance. So the study that I mentioned a while ago, the PROTECT trial, that has not been done for any of the focal therapy options, okay? So that's something that needs to be realized. So it's not yet standard of care. But preliminary data that we have show that there are encouraging cancer outcomes as well as very good quality of life outcomes. So the risk of major complications is very low, and the rates of preserving urinary control and sexual function tend to be good as well. I'm just going to go through very quickly here. There's many different forms of focal therapy that are out there right now, and this can be confusing to patients sometimes because which one should I choose? And again, there are no studies to show that one is better than another, at least at this point. The two forms of focal therapy that have probably the biggest amount of data behind them are HIFU, high-intensity focused ultrasound, and cryotherapy, cryoablation. transurethral ultrasound ablation, TULSA, is a little bit different. TULSA is different in that instead of inserting the device through the perineum using that battleship grid, the energy is actually transmitted through the rectum from the probe itself. So that's an advantage of the TULSA approach. Everything else here generally goes through the perineum. So ultrasound obviously uses ultrasound energy. Cryotherapy freezes the prostate. Photodynamic therapy uses light to activate photosensitive agents. Laser is self-explanatory. Focal radiotherapy. So radiation typically is used to treat the entire gland, but now people are using it to treat only part of the gland. So that's a form of focal therapy. Radiofrequency ablation, and then something called irreversible electroporation, which is what we use at Metro. I used to offer cryoablation or cryotherapy. The problem with cryotherapy, though, is that the ice ball that is formed during the process, we don't have the same degree of control over that we can with some of the other forms of focal therapy, including irreversible electroporation. So with irreversible electroporation, what we're doing is that we are transmitting and using electrical energy to shock the cells, or in this case, the cancer cells. The electricity basically generates and induces permanent holes in the cell that then basically make the cells blow up. And that is what leads to cellular destruction. The nice thing about electroporation is that we're able to control the area of destruction, the area of treatment, much better than with cryotherapy. So those are the two forms that I've had personal experience with. I've not used any of the other forms of focal therapy, so again, I cannot compare IRE and cryotherapy with any of the other ones, but I can definitely say that with IRE, it allows me much finer control over the area of treatment compared to cryo. And again, you can see here, the probes are inserted into the prostate through the perineum using this battleship grid, and we typically will bracket the tumor. So the red area here represents the tumor. We place the electrical probes around it, and then we basically shock the area using these electrodes by conducting electricity between them. And the next slide here shows you what that might look like. So this is what it looks like during the treatment. The bright areas are the probes themselves. The tumor is in the middle here. And then this is what it looks like on MRI about 3 months or 6 months after treatment. You can see that area of the prostate has been obliterated, and hopefully all the cancer with it. Again, we don't have long-term data on the cancer or quality of life outcomes for focal therapy, but what we have so far is promising. This is a study that looked at tumors in different parts of the prostate and whether treating all those different parts of the prostate in these patients led to differences in outcomes for urinary and sexual function. And the take-home message here was that sexual and urinary function was preserved regardless of where the primary tumor happened to be and where it was treated. So for who's appropriate for focal therapy? So up to 2/3 of men who are diagnosed with localized prostate cancer could be eligible. The disease should be organ confined. Ideally, there should be one spot of disease, or at least localized to half of the gland. If it's multifocal, then that's where we could potentially just treat the area that has the most significant or most aggressive cancer, and we can ignore the other areas that have low-risk disease. What do we do if cancer comes back after focal therapy, which is a potential risk of the procedure? There are a couple of options. Number one, we could retreat with focal therapy, or we could do what's called salvage therapy, where we try to cure the cancer by treating the entire gland. And the nice thing about most forms of focal therapy is that it doesn't burn your bridges. So if focal therapy fails, in most cases, surgery and radiation are still on the table and are still potentially feasible. So to close out here, the question is, what is the best treatment for patients with organ-confined prostate cancer? And to be honest, there's really no wrong answer here. The factors to consider when making a decision about what treatment is best for you, we have to consider your overall health and well-being, age. Treating a 45-year-old man with prostate cancer can be significantly different than treating someone who's 85. The aggressiveness of your cancer, your personal goals for treatment outcomes, and obviously preferences. And the important thing to remember here are, again, the results of the PROTECT trial. And again, regardless of the treatment option that was chosen, whether it was active surveillance, prostatectomy, or radiation, the risk of dying from disease was low in all three groups. So your chances of survival are pretty good regardless of what you end up choosing.